Good morning, Tiffany. How are you today?
I'm good, Regina. How are you?
Fine. It's great to see you again.
I know, it's great to see you. It's been a while.
Yep, I think last May sometime we were together at a meeting.
Yeah, the
Yeah.
ONS Satellite Symposium, I
Yeah.
think.
So we're here today to talk about some patients in multiple myeloma, specifically some case presentations regarding transplant versus non-transplant, newly diagnosed versus relapse refractory. And you have three, I have three. So from a management of neuropathy, we not only need to assess patients as far as what they're able to do,
Right.
both physically and asking questions, but as I'm sure you've experienced, some of these patients, if the treatment's working, don't want to reveal all of the neuropathy issues that they have. So that's where the key observation sometimes as an experienced nurse comes in making sure what kind of quality of life they're living as far as their neuropathy. And also that things that they explain to you or I as oh well, it's just a cramping in my leg may not really be cramping but actual neuropathy.
Right.
Is there anything else you're using in your clinic?
Well, a lot of times we'll start off right away with pregabalin, just because we find that it works a little bit better than gabapentin do. We also use duloxetine, which is also an antidepressant as well. So if you have somebody who's also having some depression, that can be quite useful to manage two symptoms at one time. I find neuropathy to be one of the more difficult symptoms to manage because it can interfere with their quality of life to such a significant degree. We've actually started using bortezomib once a week, both in the upfront population as well as relapse refractory patient, and have had a lot of results with it. We're not seeing nearly as much neuropathy with that, and there's been some abstracts at ASH and ASCO that have demonstrated similar efficacy at the once weekly to the days 1, 4, 8, and 11. So I'm hopeful that will become more of the norm, that we'll be able to use the once weekly and hopefully save some of the patients from ever developing it. Have you used that in your practice?
We have in some patients gone down to once weekly, yes. I think the most difficult object of neuropathy in general is that it is so subjective, and it is so varied from patient to patient. And so to get a good concrete handle, which we've had discussion on in the past, there's no one specific tool that is 100% useful because of the fact that the disease is so subjective. And I think that's what we're asking participants of this program to take away is that neuropathy is a quality of life issue for many of these patients, that it is a painful issue for many of these patients, that it doesn't just present as numbness and tingling, and that we need to make sure that we adequately assess for it, and that there's not just one assessment tool that encompasses it, and that you might need to take bits and pieces from various assessment tools that are out there.
Right, and I think the importance of the physical exam, if there's any nurse practitioners or physician's assistants that are watching, as far as checking for proprioception, vibratory sense, sensation both with light touch and pin prick, as well as watching their gait, and then also utilizing the caretaker, because a lot of times where the patient will try and hide the symptom, the caretaker is right there
shaking their head on the sideline.
Exactly. And so I think paying attention to those nonverbal cues is really important too. The one thing I also do during my physical exam is when I'm checking for swelling in their low extremities, I do it a little bit harder and then
see if they
have a response.
Tricky.